Good morning, everybody. Welcome to Envision New Mexico. I'm Michelle Widener, and I'm filling in for Kevin for today. So we just got a little bit of a laundry list to go through, so if you guys just bear with us. All right, just a few general telehealth guidelines. So we are broadcasting live and recording, so please remember to mute yourself. And if you can get on camera, please do get on camera. We'd love to see your smiling faces. This is just a quick CME update. So you will receive your certificate. It will be emailed to you the following month after this session. So you should be getting these ones the beginning of November. This is just another reminder. Please join the conversation. Please join the video. We would love to see your faces yet again. This is our CME disclosure, just letting you know that we have nothing to disclose and that we are accredited by the UNM CME office. AHI is one of our telehealth series where you can get reimbursements for doing case consultations. So please take advantage of that. You can do that through Molina Healthcare and Blue Cross Blue Shield New Mexico. And if you would like any other information on that, please contact Kevin directly and he can get you in touch with who you need to get in touch with. Roll call right now. So you can type in the chat box or say your name out loud to us, just as long as we know that you're out there.
Good morning, it's Stephanie Nevares-Fernandez from First Choice Community Health, South Valley.
Good morning, welcome.
Good morning. And we have Jessica Ramirez that's on as well. Welcome, Jessica. And we have Diana Lowe.
Welcome, good morning, everyone. Roll call around the table.
My name is Zach Johnson. I'm a health education consultant here with Envision.
Carol Conley, Envision New Mexico, AHI facilitator.
Good morning, everyone. My name is Emma Clapp. I'm an MSW intern here at Envision.
I'm Adam Cross. I'm a second-year pediatric resident.
Good morning. My name is Maya Trujillo. I'm a quality improvement specialist here at Envision New Mexico. And you know.
Morning, this is Elena Shera, senior statistician here at Envision New Mexico.
I'm Jane Baechle. I'm a nurse practitioner and working through Envision New Mexico, primarily with Fronteras.
And I'm Ricky Diamond. I'm a first-year pediatric resident.
Good morning, welcome. Okay, am I on now, Michelle? Okay, well, welcome everyone to Studio Envision. This is our 5th session of the Adolescent Health Initiative New Mexico. It is our goal to bring you up-to-date information and resources related to the care of teenagers. The opportunity to sign up for the certificate program is winding down. This is your last chance. If you are interested, please reach out to either Michelle Widener, Maya Trujillo, or Carol Conley, and we can help you sign up for that. We would love to have you participate as a certificate recipient. Now, I'd like to take a minute and introduce you to Jane Baechle. Since 1995, she has participated in the Department of Pediatrics at the University of New Mexico, serving as a nurse in the Division of Pediatric Endocrinology and Nephrology. She's been a nurse practitioner in the Division of Pediatric Nephrology since 2012, providing patient and family-centered care for children with diabetes, hypertension, obesity, and other chronic health problems. Her emphasis is on supporting children and families, advocating for the resources they need, and coordinating care in the community. Jane, thank you so much for taking the time and doing this presentation for us today.
Thank you. Thank you to Envision New Mexico for including me and to all of you who have signed in today. So I think that means we can get started here. Let me make sure I get this up. What do I push to advance it?
Just push
the arrow?
Yes.
Okay. So our topic today is the adolescent with obesity and evaluating comorbid conditions in the primary care setting. Objectives are 2. The first is to identify those potential comorbid conditions that are specifically associated with overweight or obesity in the adolescent. And then the second objective is to discuss the workup of selected comorbid conditions in the primary care practice. And I do mean selected because there are actually quite a long list of comorbid conditions, and I'm going to not really focus on all of them, but I hope we'll cover some key points and leave time for people to comment or ask questions and things like that. So these are just some sort of lead-in questions that just kind of set a framework here. The first question I have for people to think about is, do you wonder how to add yet another assessment to a 20 to 30 minute well visit that you have for your teen patient? I know from the sessions I participated in that time management really is an issue for clinicians. In your practice, do you need to think about, when you're ordering a workup, when you're doing an evaluation, do you need to think about what this is going to cost your patient and the family, either in actual dollars or in the time they need to spend to follow up on your recommendations? And finally, have you observed differences in the workups you've seen ordered by other clinicians and wondered, what is indicated? Or if you're like me, you look at it and say, what did I miss? Or now that I've got this information, what do I do with it? So first of all, just some basic definitions. I think people probably already know all of this information. And overweight is a BMI between the 85th and less than the 95th percentile for age and gender. Obesity is a BMI greater than or equal to the 95th percentile. Severe obesity is a BMI which is greater than or equal to 120% of the 95th percentile, or a BMI of greater than or equal to 35 kilograms per meter squared. And that's important to start thinking about because the prevalence of obesity actually has kind of plateaued in this country, although more than a third of US adolescents are either overweight or obese, and almost 21% of those are obese. But the category of youth who have severe obesity continues to increase. As you probably know, the prevalence is higher among youth from Native American, Black, and Hispanic communities. 12.5 million US children are obese. Many have one or more of these comorbidities. And we also know that obesity tracks into adulthood, meaning it carries with it increased health risks. The corollary to that, though, is that in youth who can achieve a healthy weight, who can leave the obesity category, they see a decrease in long-term health risk, decrease to the same point of youth who had normal weight in adolescence. So it means there's something to be gained by addressing this. What are the sort of major comorbid conditions? The first one I always think about, having worked with peds nephrology, is elevated blood pressure. And I'm going to make some reference in this presentation to the most recent AAP guidelines regarding evaluating hypertension in youth. And that's from Flynn et al. And among youth with pediatric overweight, POW is my shorthand for that, 3.8% will have elevated blood pressure. Almost 25% of youth with obesity will have elevated blood pressure. The second comorbid condition is dyslipidemia. That can be an elevated LDL cholesterol, but actually quite commonly it's a normal or borderline LDL in the presence of elevated triglycerides and a low HDL. That's what's meant by combined dyslipidemia. And that picture is a marker for insulin resistance. Moving on, non-alcoholic fatty liver disease. I put in parentheses presumed because a diagnosis of NAFLD requires a liver biopsy, but nonetheless, there's evidence that there's an increase in non-alcoholic steatohepatitis in youth with obesity. Pre-diabetes and diabetes. 4% of adolescents with obesity will have silent type 2 diabetes. In young women, polycystic ovary syndrome, obstructive sleep apnea, and then finally, psychosocial conditions. There's an increase in depression, anxiety, and eating disorders. Other conditions to think about, the musculoskeletal problems. A potentially urgent one is flipped capital femoral epiphysis, and neurological conditions, including pseudotumor cerebri. Now, those last two are pretty rare, but would be a reason for a pretty urgent evaluation. So evaluation always starts with the history and review of symptoms. So some potential red flags. One would be rapid weight gain and a significant increase in weight over a short period of time. That would be a little more concerning for some secondary cause of obesity. Those are rare, but that should be a consideration. And I would say that in all of these things, if you are seeing a sort of rapid pace in the development of symptoms, that should sort of move up the urgency of your workup. Snoring and daytime drowsiness may be an indication of obstructive sleep apnea. Polyuria and polydipsia, considering diabetes. Hip, knee, and sometimes leg pain, slipped capital femoral epiphysis. Irregular menses, hirsutism, and acne, especially acne that doesn't respond to therapy, would be a consideration in PCOS. Chronic abdominal pain. I said fatty liver, although that's usually asymptomatic, but youth with obesity have an increased risk of gallbladder disease and esophageal reflux. Severe headache, especially severe headache with vomiting, pseudotumor cerebri, depression, substance use, vomiting, and laxative use would be involved in some of the psychosocial issues. Developmental delay should lead you to think of maybe some kind of genetic syndrome underlying the obesity. And finally, you want to look at family history, particularly the early onset of cardiovascular disease, hypertension in family members, obesity, diabetes, and in the individual himself or herself, a history of prematurity. The physical exam, which is usually the next step in your evaluation, again, based on my experience in peds nephrology, we want you to look at the blood pressure. And I'll talk a little bit more about the blood pressure eval later, but you're going to be looking at serial blood pressure readings, not a single isolated reading. You want to pay attention to the individual stature. Youth with obesity tend to be taller, especially before puberty. So if you have a youth who has obesity and is short, that should be sending you down the path of some sort of potential endocrine or secondary obesity. You may often see acanthosis nigricans, which is a cutaneous marker of insulin resistance. In the female patient, potentially acne or hirsutism. And hirsutism refers to hair growth in a male hair growth pattern. So things like facial hair, upper chest, upper back, things like that you would expect to see in a young man, but you're actually seeing in a young woman. Tonsillar hypertrophy may accompany sleep apnea. A painful gait, antalgic gait, would suggest hip subcapital femoral epiphysis. And dysmorphologic features, again, would be important to look for in considering secondary obesity. And then the next part of this is the laboratory screening. And here I am drawing on the recommendations of the 2007 AMA Expert Committee. I'll later make reference to the article by Estrada et al., which outlines that. And that, even though they're the 2007 AMA Expert Guidelines, they're actually recently published again in 2014. And I think these are still the key points. So in youth who have a BMI in the overweight category, but no risk factors, and risk factors would include things like ethnicity, as we mentioned before, family history of early cardiovascular disease, family history of diabetes in first and second degree relatives. Also, prematurity or small for gestational age. So if this is a healthy kiddo, no significant past medical history or family history, but they're in the overweight category, they should have a fasting lipid profile. If the youth in the overweight category has any of those risk factors, or any youth with a BMI in the obese category should have the following: a fasting lipid profile, fasting glucose, an AST, and an ALT. Okay. Now, you'll sometimes see that kids, depending on where they've been seen or who did their workup, have had some other studies. And the expert committee comments on some of those. And so there's some cautions that they have about all of the following. The first one is obtaining a fasting insulin. And later on, I'll give you another quote from the same group. But basically, that is really not recommended by anyone. No expert committee or group has endorsed obtaining a fasting insulin. A TSH with a reflex 3T4, only if the youth has symptoms of hypothyroidism. You can have a mildly elevated TSH secondary to obesity alone. So test only if you have symptoms specific to hypothyroidism. The hemoglobin A1C is a little less controversial and can be used as a marker of glucose metabolism if you need to do a non-fasting option. And I'll talk a little bit more about that too. And then a screening vitamin D. This is also controversial. There are people who do it and people who don't, because it's generally recognized that obese youth are likely to be a vitamin D deficient or insufficient. And that's a function either of, or both, inadequate nutritional intake of vitamin D and sequestration of vitamin D by adipose tissue. However, I put an asterisk here because I do want to say that our UNM, Healthy and Fit Children's Clinic, does include a screening vitamin D in their protocol. So in terms of trying to look at this, I wanted to also draw on the expertise of all the people we work with at UNM. So normals. This is what you just really like to see when those lab results come back. Lipids, an LDL of less than 110, and non-HDL less than 120. So if you're doubtful that you're going to get fasting lipids, you can order a total cholesterol and an HDL, which can be done on a random blood test. And then if you subtract the HDL from the total, you get your non-HDL. And so we do have parameters to make a judgment about references for those. An HDL normally should be greater than 45. Triglyceride should be less than 90. A fasting glucose normal is less than 100 milligrams per deciliter. A hemoglobin A1C less than 5.7%. The ALT, the normal reference range, and this is from a recent guideline in the last year from the Pediatric Gastroenterology and Hepatology group. The normal for boys is less than 26 milligrams per deciliter and less than 22 milligrams per deciliter in girls. Standard laboratory reference ranges are considered too high for youth. So if your lab result comes back and it's not flagged on the ALT, you still need to look and see if your patient is under those reference ranges. And finally, blood pressure. So since we're talking about adolescents, the new guidelines really, I think, simplify this. Youth who are age 13 and older, a normal blood pressure is less than 120/80. Now, younger kids, of course, we're still looking at age, height, and gender. But in 13 years and older, we're going much closer to the reference ranges used by the adult group. So if you have elevated readings, what do they tell you? What do you need to think about? On the lipids, an LDL greater than or equal to 250 milligrams per deciliter is strongly consistent with familial hypercholesterolemia. Those kids need to go right on over to your lipid specialist. Triglycerides greater than or equal to 500 milligrams per deciliter, those kids are at risk for pancreatitis. They need to be seen promptly and probably started on therapy. On the lipids, there's a whole range of intermediate LDL values, and the significance of those really depends on what the value is, whether it's in the 130 to 159 category or the 160 to 189 group. And then once you've grouped them according to those results, you need to look at their risk factors for cardiovascular disease. And we talked about some of those. Again, family history of early cardiovascular death. In family history of lipids in excess of 240 milligrams per deciliter. Hypertension in the youth, which requires medication, is a high risk factor. If the youth has hypertension, but you're managing it with lifestyle, that's a moderate risk factor. Other high risk factors are diabetes type 1 and type 2 in the youth. Other moderate risk factors are BMI that's elevated, but not as severely, so 95th to the 97th, whereas it's a high risk factor if your BMI is greater than the 97th percentile. So what you want to do is, at that point, you have to go back to your history as well as your data and decide how you're going to categorize those kiddos. Neither of them require sort of an immediate referral to a lipid specialist if they're still in that sort of intermediate value. If they have values greater than 190 milligrams per deciliter, the recommendation is to refer to a lipid specialist. And Strata's is very clear that in her article, the LDL elevation that you see with obesity rarely exceeds 160 milligrams per deciliter. And in my experience, I can't really think of any kiddos I ever saw who had an elevation even that high. Now, granted, I was seeing youth for elevated blood pressures, and they had obesity along with that. But the typical pattern that I used to see was a normal or borderline elevated LDL, maybe low 130s, elevated triglycerides, and low HDL. So that's a much more frequent, I think, sort of picture. Intermediate triglycerides are anywhere from 130 to less than 500. If you have persistent levels above 200 milligrams per deciliter to 499, you may want to consider a referral to a lipid specialist or omega-3 fish oil. Now, the other thing that is recommended in the management of elevated lipids is that you're making a judgment on two values. So it's not just the first time. If you have elevated readings, you should be repeating it in anywhere from I think it's 1 to 2 months to 6 or so. Okay. You're not going to make that decision unless you have urgent values. You're not going to make that decision on one. Okay, elevated blood pressure. So the first issue that's near and dear to my heart is making sure that you've obtained the blood pressure with the correct cuff size and correct technique. And rather than kind of reviewing that, I want to recommend this video link, which is in the newest AAP guidelines. It's a 5-minute video. It's well done, and it talks about, I think, everything you need to know, figuring, positioning, determining cuff size, and also they go over very carefully all of the steps in obtaining an auscultated blood pressure, which is not necessarily something that people have stay in the habit of doing. So if you have an elevated reading, your initial reading from your intake for your kiddo is greater than or equal to 120/80, what do you do? The first thing you need to do is repeat it with 2 blood pressures and average those readings. Now, if the new guidelines endorse screening blood pressures with oscillometric monitors. So if you have a normal oscillometric blood pressure, you're okay. You're good to go. If you have an elevated reading, you can kind of make a decision how you want to do it. You can repeat oscillometric readings. If those normalize, then you can use that. If, however, they're still elevated, you need to obtain auscultated readings, because your classification of a blood pressure, if it is abnormal, if it's elevated, needs to be based on auscultated readings. You have to confirm oscillometric readings with auscultated data. And then you're going to monitor and follow those kids based on which classification you put that individual blood pressure in. I'll talk a little bit more about that later too. The other thing I want to say is that the AAP guidelines recommend in this monitoring process that if you're bringing kids back for a follow-up blood pressure because you have initial high readings, in your second visit, you should be doing arm and leg blood pressures. So both arms and one leg, which is a sort of a screen for a coarctation. Right. And then if you think you're going to make a diagnosis of hypertension, it still relies on elevated readings on 3 occasions. The data shows that only, I think, about 4% of youth with initial blood pressure elevation will go on over all 3 visits to be diagnosed with hypertension. And if you do have hypertension, here is your workup. Again, you're going to look at your risk factors for secondary hypertension. You're going to go back and look at your past medical history, particularly for history of UTIs or prematurity. Family medical history, is there hypertension in the family or other cardiovascular disease? You probably, since this is an adolescent with obesity, you've probably already done a diet assessment. You want to make sure your diet assessment includes a sense of what their sodium intake is. And I always ask about caffeine intake in detail. You've probably already done an activity assessment. You want to make sure you have a good sleep assessment, because obstructive sleep apnea or sleep disordered breathing can independently lead to high blood pressure. You want to look at all the potential medications which can increase blood pressures, and that is both prescription medications, over the counter, including common ones like non-steroidal anti-inflammatory drugs, supplements, herbal remedies, things that the kids, hear about from their coaches or their, teammates about this will, increase your performance or whatever. And finally, substance use, tobacco, alcohol, and then, any drugs of abuse. Now, the new guidelines simplify the laboratory workup. It used to be a bit more extensive. The basic laboratory workup now is a BMP, and what you're looking for is renal function and electrolytes, and a urinalysis where you're looking for proteinuria. You may have already done a lipid profile. If not, it's recommended that you include that. Other laboratory studies are recommended if they're indicated clinically in the history and physical, or if your initial readings are abnormal in some way. So if you initially have a reading with proteinuria, then you may need to go back to, your laboratory workup and do further testing. The new guidelines say that a renal ultrasound should be done if there's abnormal renal function or proteinuria. So we used to pretty much automatically do a renal ultrasound. The new guidelines don't necessarily indicate that you need to do that. And I've been talking a little bit to our peds nephrologists, and they're in the process of really looking at these guidelines to see how what that's going to tell them about what they want to recommend as specialists. So, there may be some, next time we talk about this, there may be some changes. An echocardiogram is done prior to using antihypertensive therapy. So not automatically, but if you think you need medication, they recommend an echocardiogram. It also plays a role in the evaluation of a youth with hypertension for sports participation. And finally, these are the reasons that I think you would want to refer or consult. And these are pretty consistent with some guidelines, prior guidelines from peds nephrology. If you have hypertension in a youth with a normal BMI, that should be a red flag for secondary hypertension. If you have any risk factors for secondary or hereditary hypertension, proteinuria or abnormal renal function, and stage 2 hypertension. All right, abnormal glucose. Prediabetes can be based on a hemoglobin A1C of 5.7 to 6.4%, or a fasting glucose of 100 to 125 milligrams per deciliter. CLISH recommends obtaining an oral glucose tolerance test in the presence of prediabetes. And then the question of fasting insulin. Here's the statement, consensus statement. This is the same group that did the 2007 guidelines. The authors do not support laboratory screening for fasting insulin because current evidence does not indicate changes to treatment based on results, and insulin levels may be low if a patient is losing insulin secretory ability. 40% of children who are diagnosed with diabetes were asymptomatic. A diagnosis of diabetes requires labs on 2 separate occasions. It can be a fasting glucose greater than or equal to 126 milligrams per deciliter, a 2-hour postprandial glucose greater than or equal to 200 after a 75-gram glucose load, a hemoglobin A1C greater than or equal to 6.5%. Except unless you have the case of a child with symptoms consistent with diabetes and a random glucose of greater than or equal to 200 milligrams per deciliter. And then most of the recommendations suggest specialty consultation and co-management. And in looking at the question of a diagnosis of diabetes, even with a youth with obesity, they recommend an evaluation to confirm whether it's type 1 or type 2. PCOS, or hyperandrogenemia in the young woman. The 2 characteristics here are an abnormal uterine bleeding pattern. This can be primary or secondary amenorrhea, oligomenorrhea, which would be fewer than 9 periods in a year, or excessive uterine bleeding. And then either clinical or laboratory evidence of excess androgens. That can be a persistent testosterone elevation, moderate to severe hirsutism, or moderate to severe inflammatory acne. The lab workup is intended to confirm excess androgens and also to rule out any other causes of irregular menses and hirsutism. And first of all, of course, you want to rule out pregnancy. The recommended laboratory workup is a morning sample for 17-hydroxyprogesterone, total and free testosterone, sex hormone binding globulin, DHEAS, androstenedione, LH, FSH, estradiol, prolactin, TSH, and a free T4. And that is the laboratory workup. Estrada recommends that if you diagnose PCOS, you want to go back and do, in this case, you would do fasting insulin and an oral glucose tolerance. All of the recommendations are that these studies should be performed only by a lab that does ultrasensitive pediatric assays with pediatric reference ranges. And typically what you'll see if you have a PCOS is a mildly elevated or normal total testosterone, elevated free testosterone, low sex hormone binding globulin, and mildly elevated DHEA and androstenedione. Significant elevations in DHEAS or total testosterone indicate an urgent referral for a potential androgen secreting tumor. All right, elevated ALT. Once again, diagnosing NAFLD requires a liver biopsy. The standard laboratory reference ranges are inappropriately high for youth. And again, here too, we are going to be making our recommendation for our determination based on repeat labs, anywhere from 1 to 6 months. And before you would begin to act further on an abnormal lab, you would want to see that they persisted over a period of about 3 months. So again, there are the normals. If you have a youth who falls in the category of elevated, but not twice the upper limit of normal, which would be a value of 26 to 51 for males and 22 to 43 for females. The recommendation is to follow those youth kind of based on your clinical judgment, what those lab values were, how the youth's doing with addressing diet and weight and things like that. If the values are more than 2 times the upper limit of normal, they should have a laboratory workup to look for other causes of elevated liver enzymes. And I mentioned there below, the workup is really extensive. And even, a lot of the people I read, including Estrada, recommend that you consider, before you're ordering, at least consulting a subspecialist about what to include in your workup. If, however, you have a youth with a value greater than or equal to 80 milligrams per deciliter, they should be referred to pediatric gastroenterology or hepatology. So kind of wrapping up a little bit. In the overweight youth, you want to screen if they have, with laboratory, the complete laboratory workup, if they have risk factors or obesity. And there's your laboratory workup. You're going to do a blood pressure. You're going to do a sleep assessment, a depression screen. And if you want a non-fasting option, it's a total cholesterol, HDL, and a hemoglobin A1C. If you diagnose hypertension, you want to add a basic metabolic panel and a urinalysis. You may have indications for renal ultrasound and echocardiogram. Diabetes mellitus, you need to have repeat labs. That can include a fasting plasma glucose, an oral glucose tolerance test, or a hemoglobin A1C. In pre-diabetes, you want to obtain an oral glucose tolerance test. A PCOS, a kiddo with PCOS profile, you want to either confirm with a laboratory workup if you can obtain that, or refer to either pediatric endocrinology or to women's health. And finally, if you have an elevated ALT, you want to monitor that. You might work it up or refer based on what the elevation is that you see. Ongoing management. So this is about evaluation. So I'm not really going to talk about treatment, but basically first line intervention for everyone. Every one of these is healthy lifestyle practices. If you had normal findings, you want to recheck lipids in 3 years, a glucose in 3 years. This is a change. Blood pressure in a youth with obesity should be checked at every healthcare encounter now. And ALT should be rechecked after, I think the new guidelines actually say 2 to 3 years. If you see significant weight gain or other clinical changes, you might consider an earlier reevaluation. If you have abnormal findings, if you have elevated blood pressure, if your blood pressure is categorized in the elevated blood pressure range, and the new guidelines now use the term elevated blood pressure instead of prehypertension, again, to be similar to the adults, you would check a second time in 6 months and a second time in 6 months after that. If the youth has oh, and by the way, elevated blood pressure is a blood pressure of 120 to 129, but less than 80 for the diastolic. That's a little different from the adults. If your initial blood pressures are categorized as stage 1 hypertension, which would be a blood pressure of 130 to 139 over 80 to 89, you should recheck in 1 to 2 weeks. If it's still stage 1, in 3 months. And at that point, you would begin your workup. And of course, all this time, you're working on, strategies to address it. Stage 2 hypertension is a blood pressure greater than or equal to 140 over 90. You would check in 1 week. And these kids, you're going to refer. And in fact, the recommendation is to refer within a week. So you might even check, you're going to pretty much be right on top of this. If your LDL is less than 130 milligrams per deciliter, you check again in 1 year. If it's in that intermediate range of 130 to 189, you check in 3 to 6 months. Elevated triglycerides, again, borderline, or which is less than 130, you'd recheck in 12 months, in 6 months if it's a bit higher. And if you have prediabetes, you should check annually if the oral glucose tolerance test is normal. So finally, this is a kind of kiddo that I made up, except that he kind of reminds me of a lot of kids I met, just a little of this one and a little of that one. And so I put this out here if people want to talk about it. So this is a 15-year-old male, new to your practice. You've never seen him before, and he's there for a well visit. And he says he's fine, he has no complaints. His past medical history is negative. He's basically been a healthy guy. No one ever told him there were any problems. The family history is positive for obesity. The grandparents have type 2 diabetes. He says no tobacco, no drugs, no alcohol. Review system's negative, he feels fine. You measure his height, and he is at the 95th percentile. His BMI is at the 95th percentile, so putting him in the category of obesity. And the mean of his auscultated blood pressure, so you did the whole, scene on blood pressure assessment, and his mean blood pressure is 131 over 68. Otherwise, his physical exam is normal. So, some things to think about. What would you plan to include? And what constraints or obstacles would you anticipate needing to consider? Thinking about your kiddos, your practice, what might you want to look at? And any further comments or questions?
Well, I would say maybe something for the constraints and obstacles is they have a past medical history of his family having diabetes. So like a lifestyle change for the family would be, something really major that they would have to consider.
Yeah, definitely. I mean, he has plenty of reasons here to tell us that that you want to have a conversation. You want to you want to ask if it's okay to talk about his weight, and start to try to get an idea of what he thought about, if anything, and try to start that conversation.
I would ask a detailed caffeine intake history or other sources of stimulants, things that can drive up his blood pressure at today's visit.
Okay. So he definitely, by the new guidelines, he should come back in a week or two for another blood pressure check. And, I would suspect that he has a very good possibility of being one of those kids who blood pressures normalize over the series of checks, which is by and large the majority of kids. But yeah, he should be back. And then would you all, what other, I don't think I caught everything you said. Anything else you would want to do in the way of your workup at this point?
To be honest, if we were to see him in our clinic now, we would probably do an endocrinologic workup at this point. I wouldn't wait. I probably would do an A1C since it doesn't require fasting while he's in the clinic at least, and also get a non-fasting glucose level just for reference. Because even the type 2 is often, acquired in adults. It has a strong epigenetic influence in children, very strong. So he does have a high chance for that, even with history as well as with his current body habitus.
Yeah, even if his weight was in the category of overweight, his family history would point you to doing, to doing a workup. Whether you did the fasting workup, if you thought, this is the first time you met him, so it's like, I don't know this family, is this kid gonna ride off into the sunset and show up in, 2 years when he, when he needs another physical for something that he wants. And so obviously a non-fasting option is something you can do right there in the clinic.
One of the audience, Amanda, said that he could also have his blood pressure done by school nurses, too, if that makes it easier instead of them having to go to the clinic, wherever that would be, for any type of follow-up.
I'm glad that, I don't know who you are, but I'm glad you brought that up.
It was Amanda.
Because, I'm going by the newest guidelines. And the guidelines actually advise against using school blood pressures in the diagnosis of hypertension, which is new, and that's different from something that I've seen. It's different from what I've seen our peds nephrology group do. But now they specify that doesn't apply to school-based health centers. It applies to just doing them, like in the health office, like, come on in. So I put that out there. It would suggest that we should maybe use some caution in doing that. Now, it might be helpful to do that as sort of provisionally. So let's say they're getting normal blood pressures, and you feel like the blood pressures they're getting are accurate, then that might tell you can relax. But if they're elevated, I think what the guidelines say is you should not say, okay, well, I have my clinic blood pressure and I have 2 from the school nurse, so he has hypertension. I think that's the sense I have from the guidelines. But that's an excellent point. And, I say that because literally it's spelled out. I want to tell you that the new hypertension guidelines are 72 pages long.
Wow.
Now, about 40% of that are the references, so they did a lot of work. But still, the sort of the text of the article is 42 pages. So there are a lot of new guidelines. I think I know from talking to by email with Dr. Staples, one of our nephrologists, that the specialty group, the peds nephrology group, line can email, I'm blocking the name, web pages or whatever, the things that people use to communicate among themselves, those big mailboxes are already looking at these to see how workable they are. Mm-hmm. So I think some of this may evolve, but I'm glad you brought that up because that is something that Really? Okay.
And a follow-up question to that, she wanted to know if you know why they would put those in the guidelines.
I'm not sure. I think I'm pretty accurate on this, but I think the issue gets back to one of the first things I mentioned when we're evaluating blood pressure, and that is making sure you have good blood pressure technique and positioning and determination of cuff size and things like that. And I think the concern is it's hard to control that outside of your clinic and your practice. I know when our peds nephrology group put together they put together like a little standard prescription to, because they do use school nurse data to some extent. They put together this little standard prescription that outlined how the child's blood pressure needed to be measured, which cuff they wanted used, a reminder about position, a period of rest before, how many readings, interval of time between readings, etc. And so I think that was a big part of it. I do think, though, that the guidelines endorse using feedback both from school nursing and from home blood pressure monitors in youth who are on therapy to monitor therapy. So I don't think they're saying, forget the school nurse. I think they're just sort of cautioning how to use that data.
So one question, Jane, I thought of is maybe because we think so much in New Mexico about access to care and how difficult that is for many people in our state and their communities. How then, like what resources or just guidance would you give a provider, say in Quemado, New Mexico, with no access to specialists unless they want to truck that kid in? How could they, do these kind of workup, feel confident in where they're going with their diagnosis, but also some strategies maybe to manage it in their own clinic? Like, are there resources you would recommend? Or, and I don't mean to put you on the spot, but I think a lot with my work in school-based health centers and primary care clinics around New Mexico, we run into that all the time. This is great, but I have no specialists.
Well, honestly, I read the new blood pressure guidelines. Now, some of the other guidelines I think are pretty straightforward. And as far as things like assessing lipids and glucose, I think probably a lot of even rural primary care offices are going to have options for laboratory assessment, and hopefully even the people in the rural areas know how to access subspecialists, whether they're here at UNM, which has a system I know, or in other states. Do they have access to subspecialists to get them on the phone and say, this is what I'm looking at. Can you give me some guidance?
Okay.
Now, the other thing is when I'm reading all of these now, since I'll be working with Fronteras, I'm thinking, I'm going to be seeing this child in a direct care visit, and what am I going to do? And I do have some questions. I think about the new blood pressure guidelines because as far as the process for collecting your basic data, it's really very well done in the new guidelines. It's very primary care oriented. Okay. It is, this, in that sense, the guidelines are very primary care focused. And in fact, one of the two major authors, I only put one name up there, but the other major author was I think is a family practice doctor, primary pediatrician. So these were written both from the subspecialty side and on the everyday primary care side.
Okay. I
think it is going to be more of a challenge when you get to some questions about how do I get an echo, or most renal ultrasounds, I think in a teenager who is able to follow directions and, hold still, I think you can generally you're going to get good ultrasound data. But I do think we're going to have to see how some of this works out. And that, in fact, was exactly what Dr. Staples said when I asked some questions. That the people who are commenting on this are the folks from rural and serving rural areas. So, it's going to be a good question. Now, as far as treatment, and again, I didn't talk a lot about treatment here, but the guidelines are great for that too. So they are really good. They talk about diet intervention, and if you just want to find 1 or 2 diets that you can recommend to anyone, regardless, it's either the DASH diet or the Mediterranean diet. They're not much different in many respects. And they both have all of the elements of the 5210, or you name it. That they're plant-centric diets. So there's good information there. And if you are in a primary care setting and thinking you need to start antihypertensive medications, they have guidance for that, which ones to use, where to start, how to increase the dose. And finally, I think the other thing about the guidelines that I didn't mention, but the hypertension guidelines are very clear that when the primary care clinician has gone through the process and they have those 3 elevated blood pressures, they should make the diagnosis of hypertension in primary care. You don't need to feel like you have to have a kid travel to Albuquerque or wherever. So in that sense, I think it's intended to empower people in primary care to make a decision. And one of the questions I asked too is, well, if we don't have access to an echocardiogram without people traveling 5 hours or however many hours, and the guidance I got was no one would fault you for making a clinical decision. So,
well, thank you for that. Do we have any other questions?
Let me just show you quickly the references. So I think people can access this after the meeting as well, right? So there's the Estrada article. Underneath it are the new clinical practice guidelines for screening and management of high blood pressure. Up to date, I think is an excellent resource if your clinic, has that subscription where you can just get on there. The authors on Up to Date keep those things. They review those and update them very regularly. And then finally, that last citation, the Voss citation, those are the most recent guidelines from, it's a long name, but basically the PEDS GI and hepatology group. And again, their article is also excellent because in the back they have a 2-page summary of all of their recommendations, one after the other, building one on the other. So it's really an excellent resource if you're looking at a kiddo with some elevated ALT. I know those guidelines come recommended by our pediatric GI program. And also the recommendation to refer for a reading of 80 or about milligrams per deciliter. That's consistent with their as well.
Thank you. Well, if nobody has anything else, we will adjourn for the day. Have a fabulous day and see you again next Wednesday.